antimicrobial use in acute care, and thinking about it in the context of not just outpatients, but in all of the community. So I'm going to touch upon some of the things I've said before, and I want to emphasize this concept of we really need to look at things in a whole healthcare economy approach. This is a very in Alison by two of our amazing colleagues, Monty McLeod, one of our lead pharmacists, and Rahila Ahmad, who is an expert in policy, research and social sciences. And I really would commend this to us all. I think it is quite extraordinary that we talk about One Health the whole time and about how critical it is that we look at prescribing and the use of antimicrobials in agriculture and in livestock, but yet we can't manage to look at it across whole healthcare economies, across the whole patient journey. So I feel that before we talk about, you know, the amount of antibiotics used in fish farming or whatever, we really need to get to grips with working together in the human healthcare sector in terms of understanding what goes on and how it's all connected. So it's really important that between the sectors, tertiary care, secondary care, primary care, long-term care, that they work across in terms of sectors, but also vertical integration. I mean, patients are moving between all of these groups. We need to look at this together. We have to look at strategies that look at the whole healthcare economy and move to that. And it's really, really hard because we're actually working against systems that are creating barriers for us. We are working in systems that have barriers between these sectors, and we need to find a way of working across them. So it's really, really important that we do that. I said patients are moving all around all of these sectors all the time, and our services, our data, our EPI, our prescribing, our stewardship also need to recognize this. And you've heard once before at this conference from our colleague, Professor Paul Allen, and I want to flag this really beautiful work. And I mentioned at the start of my talk about how critical it is that we have systems that we can look at our interventions to make sure we are not harming people, that we are not preventing access to when it's needed, and we can then use that data to reassure policymakers, the public, the media, about how critical this is and that the interventions are safe, or that we can rapidly identify if there's been any changes. Anyway, this is beautiful work, and it showed that a variety of policies around stewardship in the community and primary care were working very nicely and not at the expense of seeing rises in other infectious diseases. And it could only be done by developing an integrated system. So it's critical that we think about community prescribing in the context of COVID. So there's very little data out there at the moment. And I'm just using this. This is one paper from the US that came out in JAMA. It actually wasn't really about community prescribing, but buried amongst it was some really interesting stuff. So you can see on that figure the massive, completely bonkers rise in the use of hydroxychloroquine. So this was a study looking at all outpatient prescribing, and so you can see the massive rise in hydroxychloroquine. But what's really interesting is that little line along the bottom there, that dark blue or black line, amoxicillin. How extraordinary. So buried amongst that paper is this incredible reduction in the prescribing of amox. So there's also some other interesting stuff about how community prescribing has been developed and the role of telemedicine, which may promote or not antibiotic prescribing. And then we have got some local data, I can't show you this right now, but is demonstrating actually quite a marked reduction in community prescribing for a whole variety of reasons. We don't yet, of course, know if that's to the detriment of clinical outcomes or not, or the impact of AMR on not, but it's actually really interesting that actually it looks like the community prescribing has gone down significantly. So we'll watch and wait. I mentioned this already, I won't dwell on this, but I just think we have to be so mindful of the disruption in our healthcare systems in terms of how we manage vaccine programs and how we manage MDR-TB. So globally, if COVID compromises both of these, we are going to be in huge amounts of trouble. And the work, there's some lovely work already from South Africa, and there's other work now being published, which is demonstrating this phenomenal impact that will have its toll on MDR-TB and indeed on AMR more generally, with the potential disruption in immunization.